Today we are talking about the operations of bone sarcomas. This is very important because these diseases are so diverse, can occur in very different ways, can appear in different age groups, and above all, the operation is truly a great challenge. For this, we are speaking with Professor Dr. Andreu.
Of course. First of all, thank you very much for the invitation. I'm glad that we have the opportunity to talk about this today. So, I am an orthopedic oncologist by profession. I have been treating patients with bone and soft tissue sarcomas for almost 20 years. Since the summer of last year, I have been in Essen as the head of the Institute for Interdisciplinary Sarcoma Therapy and Research in the Clinic for Tumor Orthopedics and Sarcoma Surgery here at our West German Tumor Center.
When we are talking about operations now, we usually assume that the diagnostics are already completed. That is, the tumor is already known, that its name, size, location, and so on are known. You already mentioned, however, that maybe before the operation can really start, a special kind of diagnostic might still have to be done specifically for the operation.
Exactly. You are absolutely right. When the patients come to us for surgery planning, we assume that the diagnostics are complete. However, it may be that the diagnostics were not done in our facility, and the biopsy was also not done in our facility. And sometimes we have imaging diagnostics that may not be very up-to-date. Images that are 2 or 3 months old. Of course, I think none of us would necessarily be happy to go into surgical planning based on outdated imaging as those affected. We would certainly like to say, gosh, maybe the surgeon should take a close look at how things look for me today. Furthermore, there are some illnesses that we might discuss in more detail later, which are initially treated after diagnosis. During this pre-treatment, there can also be changes in the body, especially around the tumor area. So, when it comes to planning the surgery, we need up-to-date images that clearly show us the current status.
They said if, for example, someone undergoes chemotherapy before the operation, then the goal of the chemotherapy would actually be for the tumor to become smaller, right?
Not necessarily, actually. So it's always funny when the surgeon talks about chemotherapies. I am sure that a number of pediatric oncologists and medical oncologists might say, for God's sake, why? But with bone sarcomas, there are 2 main groups that benefit greatly from chemotherapy. These are osteosarcomas and Ewing's sarcomas. Chemotherapy is carried out for these diseases because back in the 1970s, we had the experience that if we only operate, in quotes, only after diagnosis, and are also very radical. Still, we saw that the vast majority of those affected develop metastases within a very short time.
So metastasis?
Metastasis.
Oh, okay.
In the rest of the body. And from that, it was recognized, okay, the operation does not seem to be sufficient for these 2 entities. And that's why the first studies were initiated, where additional drug therapies, that is, chemotherapies, were also carried out, and where it was also seen within a very short time that the survival expectancy of those affected could be significantly improved through chemotherapy and surgery, through the combination. That's why chemotherapy is being carried out. In the case of osteosarcomas, which are tumors that can also form bone tissue within the tumor itself, it is possible that the tumor cells disappear due to the chemotherapy. But the built bone, the newly built bone, will not decrease. In other words, we usually see in the images that the tumor, if at all, experiences a very slight volume effect from the chemotherapy.
Oh, okay.
With Ewing's sarcomas, it's a bit different. They are softer, if one wants to put it roughly, and they are also chemosensitive. Chemosensitive means they respond well to chemotherapy. And with Ewing's sarcomas, it can actually be the case that we see the volume of the tumor, the extent of the tumor, significantly decrease under chemotherapy. Because when we plan the surgery, we don't rely only on the scans after chemotherapy, but also consider how large the tumor was before treatment. That's why the reduction in volume isn't always a big advantage, and not necessarily the main goal of chemotherapy.
And if you say you need new images before the operation can start, do you do that on site here? Or does one have to go somewhere else to get the images? Or how does that work?
It depends on where the patients are treated. If the chemotherapies take place in our facility, it may be that the imaging is also done here. For those who undergo chemotherapy near their home and come to us for surgery planning, consultation, and eventually the actual surgery, we do not have the capacity to conduct outpatient examinations. We generally recommend that the examinations be done locally and brought to us. We also provide clear recommendations on how the examinations should be conducted.
Okay.
And if there are patients who come to us and have had no opportunity to get current images, we have outpatient affiliated partners where we can quickly get an appointment and where we can then refer the patients.
Yes. Okay. When we really get to the operation, I think one of the most important messages is that you absolutely must go to a sarcoma center.
Exactly. Specifically, a sarcoma center where there is also experience, particularly in the treatment of bone sarcomas.
How do you find that?
There are different ways to find sarcoma centers. The German Cancer Society has certified a number of centers for the treatment of specific types of cancer. And the results, the certified centers, are listed on a website called OncoMap. You then have to choose what you want, in this case, a sarcoma center, which is also then certified for bone sarcomas. And then you can look nationwide in Germany, where such sarcoma centers certified for the focus on bone can be found. There are also other certifications, for example, the Eurocon certification from the European Union, roughly speaking. You can also access and find them through the websites accordingly.
Maybe you could say a few words about that. Why is it so important to go to a sarcoma center?
There's thousands of reasons. So basically, it can be simply stated. Someone who does something every day has more experience, more expertise in that one thing. That one performs. So when I talk about very rare tumors, and let's say I only perform such an operation once a year, or maybe once every 2 years, then even if I consider myself a very capable, highly skilled surgeon, it's still, I would say cautiously, rather unlikely that I can do it just as well as someone who does this kind of procedure all the time as part of their everyday work. That means performing these operations every day, every week. That's the first thing I think is plausible to everyone. There are a number of studies, evaluations, and examinations that have shown that the surgical treatment of bone sarcomas in experienced centers is effective. And yet, there is always debate about what exactly constitutes an experienced center and where exactly should the boundary be drawn. But independent of that, the surgical treatments in experienced centers are associated with a better outcome for those affected. Better outcome means, on one hand, the likelihood of the tumor returning is lower.
That is really important once again. Okay, I think we will come back to this point later. We have already taken a brief look. Is it actually standard to have another therapy, like chemotherapy, before the operation? Or does it depend on the situation?
It largely depends on the tumor, and that's where it starts to get a bit more complex. Bone sarcomas are rare. We do not know exactly how many we have per year in Germany, but we estimate that we have approximately plus or minus 450 new cases per year.
In all of Germany?
In all of Germany, with 80 million inhabitants.
Wow, okay,
And there we have the three big players, the osteosarcomas and the Ewing sarcomas, which we have already mentioned. The osteosarcomas occur very frequently in children and adolescents, but also in older people. The Ewing sarcomas, also in adults. And then we have the chondrosarcomas, which tend to occur in adults, perhaps older adults. And then we have a number of other very rare bone sarcomas that have special characteristics. I will now just mention 2 or 3 names, such as chordomas, which mainly occur in the area of the spine, or perhaps adamantinomas, which occur almost exclusively in the tibia.
Okay, where is the tibia? That is at the
Shin bone. Exactly. And each bone sarcoma is treated differently. So with
I want to ask again, is all of that included in the 450?
Unfortunately, yes. That's why I think it's natural that there can't be many people who are very experienced with it, because even in a big country like Germany, we don't have the number of cases to say, man, there could be hundreds of people just involved in the treatment of these tumors. So let's take osteosarcoma, for example. It is the most common malignant bone tumor. The standard treatment that we generally recommend with the goal of curing would be a combination of surgery and chemotherapy. And specifically, the chemotherapy usually takes place both before and after the surgery.
Okay.
It's the same with Ewing's sarcoma. The Ewing sarcomas, however, unlike the osteosarcomas, are also sensitive to radiation. In other words, radiation therapy can be beneficial in addition to surgery for some affected individuals.
Yes, the first question would be, what is actually the goal of the surgery?
For almost all bone sarcomas, the general goal of the surgery is to remove the tumor-affected bone, including a safety margin of healthy tissue around it, in one piece without exposing or opening the tumor. This means that if we have a tumor that grows from the bone into the soft tissues, such as the muscles or wherever, it may be necessary to also remove parts of the muscle together with the affected bone segment, and so on and so forth.
So you just described that you remove the tumor in such a way that you don't actually see the tumor itself, right? Which I would say sounds a bit surprising to a layperson. Why do you do that? Why is it done that way?
In medicine, it always comes down to probabilities, and when I perform surgery, what I really want is to keep the risk that the disease might return as low as possible, especially at the spot where I'm operating, because that's the part the surgeon can influence the most. In order to reach this goal, that the tumor will hopefully not return at the same spot, so that we avoid what's known as a local recurrence. We know that it's crucial to remove not only the tumor itself, but also a layer of healthy tissue around it as a kind of safety margin. If I operate along the tumor, or even open the tumor, we know that the probability of the tumor returning is much higher. And especially in some tumors, like osteosarcoma and Ewing sarcoma, where we also said we need additional chemotherapy, we have a good trial for the treatment. This is the first trial. We need to do everything right during the first treatment as much as it is in our hands, because if the tumor comes back, we are at a disadvantage. This means if the chemotherapy worked really well, but I accidentally opened the tumor during surgery when it wasn't planned, or if I operate along the tumor, then the likelihood is higher, significantly higher, that the tumor will return. And then it does not respond as well to chemotherapy, or we do not have such effective chemotherapies that we can offer.
That means we have to get it right the first time.
Yes, exactly.
Once the tumor has been completely removed, just as you described, that's often a major topic of discussion. These tumors can reach quite remarkable sizes, especially sarcomas. In many cases, we're talking about masses that can easily measure around 10 centimeters, sometimes even more, which is really not that uncommon.
10 centimeters would even be a tumor that we would still consider relatively small.
And then there's always the issue that there's a lot around it, which is very important. Like, I don't know, especially when it's a limb or wherever. And then there's always the question, how do I manage to remove it and still maintain functionality so that the leg and the arm or whatever can still be used well?
Exactly. That's why treatment in an experienced bone sarcoma center is important, because we don't just speak theoretically. Well, this muscle actually does this. So, if I were to remove it, this and that should happen. No, we experience this every day. I know pretty well from the feedback from our patients what to expect when performing this or that operation. Basically, it must be said that the surgical treatment of a bone sarcoma varies for each individual affected, depending not only on how large the tumor is, not only on which bone or part of the bone it has affected, but also, is the tumor growing into the soft tissues, and which soft tissues around the bone are affected, and so on and so forth.
So that can happen. You always imagine that the bone is something hard and clearly defined. But with a tumor, it can happen that it really grows into the soft tissues.
Into the soft tissues, exactly. So the tumors grow out of the bone at different speeds in different cases because they do not respect the anatomical boundaries, the areas of our body. They just want to gain more volume to become larger, and then it is relatively irrelevant for the tumors whether the bone has a certain shape. As long as the tumor does not grow too quickly, it naturally tries to take the path of least resistance. But at a certain point, it also tries to grow beyond anatomical boundaries and often, very often, grows into the soft tissues.
And do they also have to be removed then?
Exactly. So, wherever the imaging indicates tumor tissue, it's essential to remove not only the tumor itself, but also a layer of healthy tissue around it.
Yes. When you have to remove affected soft tissue, the question is always, can, for example, limbs, arms, legs be preserved or not?
In most cases of individuals who have a bone sarcoma in the limbs and extremities, meaning in the arm or leg, we can remove the tumor without losing the leg or the arm. However, there are few patients where the goal of completely removing the tumor with a safety margin around it cannot be achieved technically without losing the leg or arm, without an amputation, where we then have to talk openly with the patients and say, this is doable. Technically, I can manage it, but the reconstruction I can offer will ultimately mean, especially in the area of the leg, that the function is worse than what can be achieved with an amputation. And we also need to openly discuss the goals of the operation, what is important for the person concerned, and come to a therapy decision together.
But if we stay with the aspect that you can preserve the limbs, what is currently available in that regard? Bone is something that is super important because it carries everything, so to speak. Without bones, nothing works. What possibilities are there these days?
So, the vast majority of tumors occur near joints. This means that during the operation, we have to lose one of the joint partners. Let's take the knee joint as an example. It is formed by the thigh bone and the shin bone. We also have the kneecap, but we'll leave that aside for now. So, if the tumor is in the lower part of the femur, and I therefore remove the entire lower part of the femur, I still have the shin bone completely intact, but the joint itself is no longer functional. Because the ligaments responsible for the stability joint and also the cartilaginous surfaces that ensure the joint can move smoothly are simply no longer there on one side, we can no longer reconstruct it as it was before.
For this reason, for most of the bone sarcomas, we use so-called tumor prostheses for reconstruction.
Tumor prosthesis. I've never heard that word before. What does it mean?
A tumor prosthesis is a special type of metal implant that has been specifically developed not only to replace the joint surface, as is the case with normal artificial knee or hip joints, but also to remove the joint surface as well as the affected portion of the bone.
And I actually brought an example with me.
Oh, yes, please show us that.
So this is what a tumor prosthesis would look like. This is the joint part of the prosthesis. In this case, it would be a knee joint, or the prosthesis itself is called a distal femur replacement, meaning the lower replacement of the thigh bone.
The tumor in this case is located in the lower part of the femur. That part has been replaced. And for that, we have on one side a metal prosthesis, which we can vary in length with different sleeves so that we can reconstruct the length we have removed as accurately as possible.
Then we have the joint mechanism here. So this is the part that allows us to reconstruct the stability in the knee joint. So this small pin here takes over the function that the ligaments previously had.
Oh, yes, exactly. Okay.
This plastic part here is for the smooth movement in the joint. And then we have on one side down here the joint partner in the shin bone. The whole thing has to somehow come together with the healthy bone. This part of the prosthesis does that. And the whole thing must, of course, also connect with the healthy part of the femur. This is done by this pin here, which is inserted into the healthy bone and connected to the prosthesis with screws. And this is how it looks in the end. This is how we reconstructed the bone defect.
That looks golden. Is that gold?
No, that is actually not gold. That is titanium nitride. It is a special coating that has certain advantages, and that is actually silver.
And what I find really exciting now, where are the muscle tendons reattached? Because in the end, you have to reconnect with the muscles so that you can move it. How does that work?
Great question. But again, it depends on where I am operating. In this example, we have the lower part of the femur. There are a few muscles that attach in this area that we remove. These muscles can be detached from the bone without needing to be reattached, without experiencing a significant loss of function. This is partly because the detached muscles still scar, and the attachments of these muscles were not so important for the function of the leg.
Now I am confused. So you say that most of the muscles are actually attached more to the shaft of the bone and not to the knee? Or what? Where are the muscles attached so I can move my leg?
In the case of the knee joint, most of the most important muscles are on the shin bone. As long as I preserve the shin bone, for example, the extensor muscle for the knee joint, the most important muscle for walking, is intact.
It runs along the bone, over the joint, and attaches to the shin bone. This means that when I do this reconstruction, because the tumor was located at the lower part of the femur, there is no additional need to reconstruct these soft tissues, these tendons. It looks quite different, however, if the tumor is located in the upper part of the shin bone, because then we will have to remove the upper part of the shin bone, where the so-called extensor tendon attaches. It is then detached, and in Germany, in most cases, it is reattached to the prosthesis with an artificial tube that is placed around the prosthesis.
So I basically have, let's say, plastic, and then I can attach it back to that.
Exactly. That's exactly how it is. Exactly. And the same applies to tumors that are located at the upper part of the femur, because there are also many tendons there that are necessary for the stability of the pelvis when walking, when running. Operations in this area also mean that we have to reconstruct as many of these tendons as possible, unlike with the lower part of the femur.
That sounds really exciting, and I have to ask, since when have these types of operations existed at all?
Now, I would be lying. So I think the first prostheses were developed in the 1960s and 70s, but back then, they were not quite so commonly available. I think there was already, in the 1980s, the possibility to implant such prostheses, but they were made specifically for each individual affected. And funnily enough, This led to the start of chemotherapy, something that we now say makes sense in many situations. That came out of necessity in the past. We need time until the operation, until we have manufactured the prosthesis. That's why we bridge this time with chemotherapy and perform the operation when the prosthesis is ready. And as far as I know, at the end of the 1990s, prostheses like these came onto the market, which are structured like a modular construction system where I have all the parts in most cases, and I can combine them as needed to perform the reconstruction as I require.
And now we briefly talked about it before. Sometimes that's not possible, and you actually have to amputate.
Exactly.
And, what would be the reason? Why must, or how? How is the scenario? What is the situation where one has to say, no, actually, we can't do that now. We have to amputate?
So, there are two main reasons. The first main reason is I cannot, to put it bluntly, preserve enough healthy tissue now so that the leg or arm still has any function at all in the end. If the tumor has completely infiltrated the vessels and nerves that are essential for the function of the leg or arm, I know I have said that I want to remove the tumor enclosed, surrounded by healthy tissue, that I cannot preserve the vessels and nerves. I can reconstruct the vessels, but not the nerves. If I also lose a lot of the muscle, at some point it makes no sense to try to preserve or insert just skin and metal somehow, because that will not work. If we consider that with a lower leg amputation, one can achieve an excellent functional result and even do much more in everyday life than with the preserved limb. In this case, then we must also openly discuss with those affected. What are the goals that are important to them? And what is the best therapy option for the person?
I mean, we all know it by now from the Paralympics, that sometimes these exoprostheses, which look quite different from the traditional limb, right? But with these springs, jumping springs, they achieve really great functionalities as a lower leg or foot replacement.
Exactly. That is, of course, the path towards competitive sports. They also look strange. One can openly say, you don't need them in everyday life, even if you do sports in everyday life, unless you really want to do competitive sports. But there are still a number of special exoprostheses that can look a little different. For instance, they now allow the affected individuals to jog, jump on wet surfaces or rocks, and push off with their feet to continue running. They allow the patients to swim and so on, so you can say, all right, these are things I can achieve with the exoprosthesis after an amputation, but perhaps not at all with the preservation of the limb in certain exceptional cases, as mentioned. And then the question arises, what is more important to me? To keep the leg, knowing that I can't do as much with it in everyday life, or rather the function, so that I get more out of everyday life itself. And that is an individual question. There are no right or wrong answers. Every person has different priorities, but it is also our job, together with the affected person and their family, to say, what is right for you, and how do we achieve what is right for you?
So that actually means that before an operation is started, there is really an intensive discussion where both options are considered. Of course, always with a certain tendency. There is probably already a basic scenario where there is more of a tendency towards preservation, or a basic scenario where there is more of a tendency towards amputation, but that it is then actually discussed openly with the patient, and a joint decision is made.
So, exactly, this is discussed very openly. So, don't get me wrong, I would never consider an amputation if I didn't think it would bring any advantage at all.
And I have said, for the vast majority of those affected, amputation is not needed. Then, the discussion tends to focus more on what other reconstructive options are available or other details. But if it comes to the point where one says, I cannot avoid the amputation, then I have to explain it in detail. Or if we believe, that we can offer both options, then we must discuss it honestly with the person. And sometimes one conversation is not necessarily enough. In that case, you have to accept a second, or, in the worst case, even a third conversation to ensure that when we perform the operation, the person affected is convinced and says, yes, that was the right thing for me.
What is the current approximate rate of preserving operations and amputations?
Well, I would say about 90% of people with bone sarcoma in the extremities undergo limb-sparing surgery, and about 10%, or maybe 5 to 10%, we have to discuss amputation.
Ah, yes, but that really sounds like a very good rate. And once the operation is done, what happens next?
Yes, that also strongly depends on what type of tumor one has. We talked again about osteosarcomas and Ewing sarcomas, where we said chemotherapy takes place before and after the operation. In other words, when the operation is over and the wound is healing, we try to refer or transfer the patients back to the treating pediatric oncologists or medical oncologists as quickly as possible so that chemotherapy can continue.
Okay.
Or, in other words, with the Ewing syndrome, where we sometimes also consider radiation therapy. That is also carried out after the surgery. But at some point, the treatment is still completed, and then it's about returning to normal life. On one hand, every person who has cancer is entitled to an oncological rehabilitation measure.
Yes.
And that is very important. If we have, in quotes, only operated, it is mainly about muscle building, gait training, and so on and so forth. But if I have also received chemotherapy for several months, or perhaps additionally radiation therapy, at some point, the entire body is exhausted. And there you need a time to recover from the entire treatment, where you also learn to cope with it, to live without this illness, and still improve the function of the affected limb. It's a process that takes time and patience, both physically and emotionally.
Is it usually a rehabilitation that is done inpatient, meaning at one location, or is it done outpatient, basically from home?
That is, of course, for each person to decide for themselves.
Okay.
Usually, after a combined treatment with chemotherapy and surgery, it definitely makes sense to undergo inpatient rehabilitation for 3 to 4 weeks. If we, in quotes, only have an operation and we have someone who already immediately after the operation during the inpatient stay shows us, I am getting along great with the new joint, then it might also be that one says, gosh, maybe this person does not necessarily want inpatient treatment. We're talking about outpatient physiotherapies or outpatient rehab.
Very good. And are there also programs specifically for children and adolescents?
There are institutions that have a special focus on children and teenagers. And additionally, here are clinics explicitly designed for the rehabilitation measures for children and teenagers with cancer, which also have an orthopedic focus. In other words, there are different types of cancer in childhood, unfortunately.
But there are also facilities experienced with children who have had a sarcoma.
And then there's the aftercare. Over how many years does that extend?
Good question. Very good question. So, follow-up care has 2 goals. The first goal is simply to ensure that the tumor does not return, or, in case it does return for some patients, that we detect it in a timely manner or as early as possible, to put it better. This follow-up care is usually carried out for at least 5 years, gradually increasing, rather, for 10 years. If we install a metal prosthesis, we know that this metal prosthesis is not meant to last forever. We know that such prostheses will need to be replaced at some point. They do not have an expiration date. It's not as if we can say, it's fine until this year, and after that, it must be exchanged. But for different patients, it can be sooner, later, or much later that we realize, yes, we will need to operate again soon. And even when the oncological follow-up is completed, for people who have a metal prosthesis, we recommend more or less once a year that we conduct a checkup with us.
Thank you very much. I believe we have really gained a great overview of the surgery for bone sarcomas, and it was truly fascinating to see this endoprosthesis. Dear Professor Andreu, thank you very much for your time.
Thank you for the invitation.